Greetings, everyone. This is Osama Ibrahim. I'm an interventional cardiologist and endovascular specialist in Jacksonville, Florida. I would like to thank Dr. Craig Walker for this invitation to present at NCBH Digital Education Series. Today, we're going to be talking about dedicated venous stents. These are my disclosures. So obviously, there's no question that we've come a long way from how we treat venous disease. This is pretty much what we had for decades, which is rat control with warfarin. As we started to evolve into understanding more the pathophysiology of venous disease, from thrombotic disease states to pelvic compression syndromes, such as May-Turner, which is listed over here, to the utilization of more and more intravascular ultrasound imaging, which made us understand better how to treat this disease, particularly with stents. But more importantly, also intravascular ultrasound has allowed us to really think differently about when we put in stents, what is exactly the end product that we want for this vein. And this basically brings us to the topic of what are the dedicated venous stents that we have at our leisure at this time. Looking at this table, we can see that there is wall stent that is produced by Boston Scientific. There's also a Vichy stent that is produced by Boston Scientific. There's Cook Medical Silver Venous stent that is produced by Cook Medical. This is not yet approved in the US. BD Bard has the Venous stent that is approved for use in the US, and Medtronic is working on the Ibrahim stent, which also is not yet approved in the US, but hopefully within the next year or two, we would hear some good news about this being approved also. There's no question about it. Each different stent brings something different to the market. The wall stent, which has been around for over 20 years, was unopposed competitor for such a long time. It's a braided stent. The Vichy stent, which is a new kit to the market, is a closed cell stent. The Silver Vena is an open cell format, such as the Venovo and the Ibrahim stent. And as we can see, there's different lengths and different sizes, and also the profile of these stents, also introducing them through 8, 9 stents. The smallest profile is the Silver Venous stent that is introduced through a 7-French stent, but obviously it's not available at the US at this time. Also, the delivery systems are a little bit different. Some of them are coaxial and some of them are triaxial. In addition to working lengths of these shafts are also a little bit different. Off note, we can say that the Vichy is the closed cell, the only stent here that is a closed cell. And the Venovo stent offers 160 length, which at this moment is the longest as venous stent on the market, at least what we have right now. This is just a side look at how these stents are a little bit different. The ones in red are the ones that are approved in the US at this time, and that's the Boston Scientific wall stent, the Boston Scientific Vichy stent, and the BD Bard Venovo stent. This is looking at the CE mark approvals and the FDA approval. This slide is a little bit old. Boston Scientific wall stent did achieve FDA approval in 2020. Now, this is what these stents look like side to side. And now we're going to go into each stent to talk about it specifically. So starting off with the Boston Scientific Vichy stent, and this basically is specifically engineered to withstand the crushing forces that we see in venous disease. And really what Vichy brings to the table is radial strength and the whole concept of circular lumen, which what we will see in a few slides ahead, that this maintenance of this circular lumen is what allows for better patency and better outcomes. If we look at the left of the screen over here, and we can see the non-thrombotic iliac vein lesions, or what we're going to call it compressed or venous compression lesions. We can see even if it's a compression, even if we're going up with a balloon, there's a waste on fluoroscopy, and that's how not to underestimate these compression. External compression can be very tough to break. And if we look underneath the intravascular ultrasound imaging, and we see that elliptical shape, this is an open cell stent under intravascular ultrasound. We see that elliptical shape does not necessarily always correlate to improved patency and need for target vessel revascularization. If we look to the left over here, we can see on these fluoroscopic images that there's no question about it, that the compression is there and that there's even stent fractures that can sometimes occur. Excuse me, moving forward, we can see that the design of the stent was basically designed to sustain two different kinds of loads, or withstand two different kinds of load. A focal load, which was basically closely represents compression, and a circumferential load was basically supposed to be representing a post-thrombotic compression. And this stent was designed in mind to overcome both these types of loads. Now, when we move forward to the closed versus the open design, the reason why they went to a closed design when they designed the stent was basically closed cell design when they designed the stent is because some of the competitors that have open cell design, they see that basically it can become elliptical shape under compression. And as we'll see, I think in the next slide, that these elliptical shaped or the compression that happens to these open cell design can lead to decreased patency rates. Another hallmark of the Vichy stent is that it has 24 strut pairs that basically encompasses the entire lumen, and that's why it allows for that circular shape that we see under intravascular ultrasound. Also, we see that it's designed to enable maximum crush resistance over here, where we can see that it has improved crush resistance compared to its competitors. Obviously, on the ultrasound, that's what the circular patent lumen that we're talking about with the Vichy stent. As we can see over here, that it's a nice circular shape versus over here with an open cell stent. This basically shows it's more of an elliptical shape rather than a circular shape. And this brings us to this very elegant study out of Korea in 2015, which basically showed that patients treated with open cell nitinol stents, if basically they show this compression, it becomes inversely correlated to the stent patency. And this is very important when we're treating with venous disease, because typically we do see this elliptical shape sometimes with some of the other stents, which, as we can see over here, becomes inversely correlated to stent patency. Moving forward, yes, the stent design, everything looks beautiful, but let's put it to the test. And this is really where all these stents are put through trial design. So Vichy, we present the VERTUS trial, and this is basically a prospective, multi-center, single-arm, non-randomized trial. 200 patients, 30 patients in 9 sites were for feasibility. 170 other patients were enrolled in 22 sites, and that's for the pivotal trial. The endpoints, we're looking at 2 different aspects. We're looking at safety, and that is major adverse events at 30 days. And we're also looking for effectiveness, and that was basically by primary patency at 12 months. So in regards to the patency, we saw a primary patency, 84%. At 12 months, which exceeded the performance goal of 72.1%. So obviously that did reach statistical significance. And when we're looking at the primary patency breakdown by disease state, we see that in a post-thrombotic state, it's approaching 80%, and in a compression state, it's approaching 96%. Obviously, from a safety standpoint, the VERTUS trial did show that 98.8% freedom from major adverse events through 30 days, and this is the breakdown of these findings. And we can see that even at 24-month results, we sustained that primary patency rate close to 80%. And even in post-thrombotic, we see it closer to 73%, and in compression patients, we see them still hanging around the 96%. Obviously, we see 0% stent movement over here, which is very important, especially in the venous space, with just 1 out of 150 subjects demonstrated confirmed pulmonary embolism and venous DVT. Now we move on to the BD Bard de novo stent, and this basically was a dedicated stent design, and it's looking to a balance between radial force and flexibility. It is one of the, I think it's the only one on the market at this time that is a triaxial deployment rather than a coaxial deployment. It offers the longest length, 160 length, and also goes up to large diameters. Obviously, the stent design itself, it's a self-expanding like no stent. It is flexible. I think one of the hallmarks is that the ends of the stent are flared 3 millimeters to ensure adequate wall apposition, or what we call anchoring, to avoid stent migration, which can typically be cumbersome when we're treating venous disease. There's 3 radial-opaque markers. These open design stents are connected through various nitinol connectors, as we can see over here and over here. It's an 8 French to 10 French profile. Diameters anywhere from 10 to 20 millimeters in diameter, and lengths 40 to 160 millimeters in diameter. Typically, it's delivered over an 035 wire. And as I mentioned before, it's a triaxial delivery system. Again, talking about the stent design, let's move on to clinical trials. And we present the VERNACULAR trial, which was basically a prospective, multi-center, non-randomized, single-arm trial. Patient population, 170 patients, 22 international sites across US, Europe, and Australia. And the follow-up was for 3 years. Similar to the VERTUS trial, there is a safety aspect and there is an efficacy aspect. The safety aspect was major adverse events at 30 days, and as we can see over here, it achieved 93.5% freedom from major adverse events at 30 days. And from an efficacy standpoint, it demonstrated a 88.3% 12-month patency rate. We can also see that this is sustained at 2 years for 84.3% patency, and more importantly, 0% stress fractures, which is kind of important. We also see that at 12 months, there was significant improvement in the VCSS pain scores and the quality of life scores compared to baseline. Moving on now to the Boston Scientific wall stent. This is not a new kid on the block. It's been around for a few decades. It is a braided self-expanding stent. It's a coaxial over-the-wire delivery system through a 9 French guide sheath. It is designed to sustain high compression resistance and, more importantly, conformability, which is kind of unique to this stent, no question about it. CE mark for iliac vein was received in 2015, and FDA approval was received in 2020. This is the various sizes that is offered through the wall stent, which has an extensive platform of sizes and lengths. This obviously just shows that 20 years of clinical data to the wall stent, 37 peer-reviewed publications analyzing over 4,500 patients. Wall stent, excuse me, literature analysis, and we're looking here in post-thrombotic syndrome patients or compression patients. In compression patients, we see weighted mean 1-year patency around 88.4%, and for PTS patient population, we're talking about 78.5%. Moving forward to the wall stent randomized controlled trial that was presented in 2018. This was a double-blinded randomized controlled trial. It was medical treatment with iliac vein stenting with wall stent for chronic venous disease. 51 patients were enrolled, 26 patients received stents, 25% were control. 27% of them were thrombotic lesions, 73% of them were compression patients. C classification, C1 to C6, and VAS pain score was greater than 3. 6-month follow-up, the VAS pain score declined from 8 to 2.5 in the wall stent group compared to 8 to 7 in the control group, which was statistically significant. And in regards to VCSS score, declined from 18.5 to 11 in wall stent group compared to 15 to 14 in the control group, which also was statistically significant. 12-month wall stent patency was noted at 92%. Idiopathic venous stenting meta-analysis by Dr. Razavi. This was presented in 2015. Meta-analysis for the safety and effectiveness of stent placement in idiopathic venous outflow obstruction. This was 37 patients consisting of almost 2,900 patients. Obviously, with the wall stent being one of the oldest competitors in the field, about almost 80% of these patients had wall stents. 3 patient population were analyzed: non-thrombotic, acute thrombotic, and chronic post-thrombotic patient populations. Complication rates within 30 days were less than 1% on this meta-analysis for bleeding and peripheral embolization and mortality. 1-year patency rates for non-thrombotic patients were 96%, for acute thrombotic patients 87%, and for chronic post-thrombotic patients, which are typically the most challenging in this group, was around 79%. Medtronic Ibrahim stent, as we said, stent is still not approved in the US, so we have limited data on it, but there was the Ibrahim study, which is a prospective single-arm multi-center international study, 200 subjects looking at both thrombotic, post-thrombotic patients, compression patients, and acute DVT patients, 24 sites across the US and Europe, with the primary endpoints looking at both 12-month patency for effectiveness and 30-day freedom of major adverse events for a safety standpoint. Obviously, it met its primary safety endpoint at 98% within 30 days, free of major adverse events. 12-month patency rates were around 88%. Freedom from clinically target lesion revascularization was noted at 92.4%. 100% device success achieved during the index procedure, no stent fractures, and statistically significant sustained improvement in quality of life at 12 months. Thank you very much.